The ways to reduce the risk of breast cancer-related lymphedema are to be more mindful about which patients actually need to have surgery in the axilla. So we remove lymph nodes in the axilla either because they contain cancer or we think that they might contain cancer. So we did that as kind of a staging procedure. So what we've learned now is that the biology of the tumors and the imaging of the axilla, for example, with ultrasound, can really give us a lot of information about what treatment the patients need, and we don't necessarily need to remove lymph nodes for all patients. So that's a big improvement. Obviously, avoiding any surgery on the lymph nodes completely eliminates the risk of lymphedema. And then if patients need to have surgery for the lymph nodes in the axilla, then it's important for the surgeons to understand the anatomy of the axilla. So we learn in medical school about the anatomy, but the thing that we aren't necessarily learning and that we aren't using in practice is the fact that the lymph nodes in the axilla or the armpit both drain the breast and the arm. And the reason that some patients will get lymphedema is because when lymph nodes are removed, we're interrupting the drainage of the lymph nodes and lymphatics from the arm as opposed to from the breast. So being able to identify those lymphatics and lymph nodes and preserve them or repair them at the time of breast cancer surgery can markedly reduce the chance of patients developing lymphedema. So that's a change in technique, in what we call smarter axillary surgery. You know, the complete removal of lymph nodes in the armpit area is called an axillary lymph node dissection. And what we're now advocating for, and what I'm speaking about today, was doing more of a selective lymph node removal, taking into account the drainage of the lymphatics and the lymph nodes from the arm and preserving those whenever possible.